This is LiveWell Talk on busting common COVID-19 myths. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's Hospital, Cedar Rapids, Iowa. You cannot turn on your TV or look at your phone without seeing some sort of headlines about the pandemic and COVID-19, whether it's new variants, whether it's mask or not mask, vaccine hesitancy, and even to the point of COVID-19 denial that it really is real, which is mind-boggling. But in any case, we thought it'd be nice to have a podcast where we looked at some of these myths, and analyzed them to see, because there may be an element of truth, it may be all mass hysteria. And to join me today is Vice President Medical Director of UnityPoint Clinic Cedar Rapids, Dr. Diehl. We're going to break down some of the common myths and take a look at why these things have developed and why they're persistent. Dr. Diehl, welcome back to the podcast. I think you've been on before.
No, it's first time, Dr. Arnold.
Really?
Thanks. Yeah. First time the invite. I appreciate it. It's first time on.
But you do listen on a regular basis, correct?
Absolutely. Long time listener, first time being on the show.
First time, long time listener, first time guest.
Thanks for having me.
Evan, as you and I've talked before, that, and I've talked to other people, this pandemic arrived in a campaign year, presidential campaign. During campaigns, everything is politicized. That is historically what happens. But the politicization, the polarization, the black and white of an issue that's incredibly gray has been persistent to the disadvantage, I think, of the scientific community on some level, as far as building trust. I think Americans in general are ruggedly independent when they need to be, and that's why they're Americans. But it certainly has complicated issues. So I kind of want to go through kind of some of the common things that we hear and just where we at, and maybe what was the nidus, or how did this start? And the first one that I wanted to ask you about was airborne versus non-airborne transmission, as well as asymptomatic transmission.
Sure.
I can remember, I was just reviewing some stuff for this podcast, that when the WHO said that it's not person-to-person transmission, and now we know that's to be patently false. Not that they were misleading people, I just don't think they knew. So what is COVID-19 airborne?
Yeah, I think there's evidence that scientifically that it can be, that it is. I think the question we don't know is is that a regular part of how people are getting it? And so I always remember when they closed down the playgrounds and talked about disinfecting surfaces and things like that. And I always just found that shocking to think I don't think we're getting the virus from, touching some plastic from somewhere else. I think most of us in the medical community are aware how influenza spreads. We get the idea of droplet spread, of sneezing, and that most of the evidence suggests that people are getting it from close contacts, people breathing and coughing and sneezing by them. So there's going to be these scientific studies that talk about transmission and ways that it's transmitted. But I think the bigger question is, how is it most commonly spread? How do we stop the biggest chunk of that? And I do think that comes back to the common sense there of some masking, of covering your cough, cover your cough in your mouth when you're sneezing, and washing your hands. And I think that's the biggest part of it.
I think you're right. I think from whether or not it's airborne, first of all, measles is known to be airborne.
Yeah.
Very, very, with a very high RO rate, meaning for every case of measles, it may be close to 10 other cases start. That's how airborne measles is. But they've never cultured, if that's the right term, because we don't really think of culture when we talk about viruses, but they've never cultured measles out of the air. It's done by looking at, well, how does it present and how does it transmit? And I think if you look at a couple of things that, to me, I think it's pretty definitive that it probably is airborne. And that is the USS Roosevelt and other cruise ships. They had people that had no contact with each other, didn't touch the same things, were not in that, but they shared the same air for a period of time. And we had transmission, and particularly in the US Roosevelt, they could, by duty assignments and logs, they know where people were, so they could say, okay, this person never came in contact with these people, and they got it.
Yep.
And the other is we know that outside events are pretty safe.
Mhm.
It's indoor events without ventilation being dangerous, and indoor events with poor ventilation are dangerous.
Mhm.
So I mean, I really think it's put to rest, but there's still a lot of controversy. There's still people that don't believe it's airborne. But you're
Yeah,
absolutely right. When it started, the fomite or the touching surfaces, that was huge. Everybody's wiping down everything.
right.
Uh, and it's probably not transmitted like that way.
Right. I mean, I know I'm not this is one of those do what we say, not what we do sort of things that none of us are perfect with masking. And I think I try to, as much as possible, in close contact with people to put on a mask. Um, but you always know there's people that have different levels of caution than you. And I've wondered when I'm outside walking my dog, in the middle of Iowa, not close to people, that I presume that as being safe. And you walk by someone briefly on the sidewalk who has an N95 on,
Yeah.
and you realize like, oh my goodness, like maybe they think I don't believe in masks. Like they're so far on that other spectrum. So it's just interesting, the wide degree of how serious people take that.
I think you can't deny the elephant and the donkey in the room to make a political pun. That it kind of depends where you're falling as far as what you believe in, and I wholeheartedly believe, particularly with the vaccine passports, that if it was reversed, that people that are for it would be against it, and the people that are against it would be for it. And there's on certain level, there's just no doubt in my mind that
Hmm.
that would be true. Um, I remember learning this when we went to Italy, that the term passport actually comes from the plague, that you had a pass to get through the port to enter these walled cities. So you had to, in some way, prove that you weren't active with the plague. So that's kind of interesting that when we think about that. It always surprised me, the asymptomatic transmission, and I want to hear your pick on. You know, People say, well, respiratory viruses don't transmit asymptomatically, but there's a lot of viruses that transmit asymptomatically. You shed the virus before you're infected. I
Yeah.
mean that's actually really common.
Absolutely. And think of how frequently, we all get a little cough or cold or sniffles that, you just have for a day. It could be allergies,
Right.
and we just don't know. And I think that comes back to a lot of these recommendations that, like, if there's any question, we don't know, like, it's just, let's set a low bar for, trying to avoid uh, populated places, and wear a mask. And there's plenty of times I woke up with a something that I usually would call allergies. That the last 2 years has put a great deal of put a little bit more stress on that. Like, oh my goodness, maybe this is COVID. So we don't know. I think it happens a lot before the last 2 years with other viruses in cold season. And what is that level of having symptoms? Is it just a little scratchy throat, or are we talking about a full blown fever?
Well, and here's another thing. I mean, you'll appreciate this as a physician. We're all day long asking patients, when did the symptoms start? What made them better? What made them worse? We're taking a history, because the history is 99% of medicine, getting the narrative from the patient. And then 1% is confirming that narrative on physical exam, right?
Hmm. Hmm.
And how have you ever been a patient as a physician, and you're a patient and they start asking you those questions? You realize what a horrible historian you are. They're like, well, when did this
Yeah,
start? And you're
yeah,
kind of like,
we don't know.
I don't know.
Right.
And the nurse asks you, and you say, well, it started a week ago. And then you sit there for a while and you go, oh, really, what, boy, it did happen at that wet. So it was about 2 weeks ago, I guess. Doctor comes in, and now it's 2 weeks.
Right.
And that happens all the time. It's happened to every clinician. But you realize patients are just not just patients. People are not reliable
Yep.
historians on when
Yep.
things.
It's really hard, and we don't know the difference between completely asymptomatic, just really mild symptoms. I knew someone that just had a headache and didn't feel that good for a day, and ended up testing positive for COVID. So was that COVID? Was it asymptomatic? Was it something else? We just won't know.
Well, I think in a related, as far as symptoms and contact, this we could do a whole nother podcast about just the stress in society prior to the pandemic. I mean, I think it's safe to say this now. I wouldn't have said it back then, but I did feel it, that there was kind of a sort of enthusiasm to cancel meetings and change your schedule. because it was so stressful prior to the pandemic, it kind of was a stress relief, and that's probably hard to explain.
Yeah.
But I felt that not just in our industry, not just in medicine, but just in everyone's industry, that it was that early on, that first week or so was like, just although it was scary, it was also kind of break from just the mundane and the stress of what we do every day.
Yeah,
And
that's really interesting.
it's really made me rethink that. Well, okay, was it important to have these meetings on a regular basis when we went without them and the world didn't end?
Right.
Um, and so I've tried to look at my life a little bit as far as what brings value to things, and I think that the pandemic's made me look at it. It's kind of just a related topic, but not
I
unrelated.
could imagine the number of, books that'll be written about these few years. I mean, there's so many societal things to study, and that first one you mentioned is like, yeah, we all kind of came together that late winter and spring, and there was a lot of you know, just us and we thinking about, even the country, the world, as humanity as a whole, we were going to get together and fight this thing. Um, and even the support that we got for as healthcare workers, I mean, that was amazing. And for most people, it's still going on. But I think what we're just seeing now is just a lot of real burnout. People are just really, really tired of still talking about it. And so some of that grace that we gave each other has worn off a little bit.
Well, we talked yesterday on the podcast, the weekly update, and I've come to this observation. I want to get your opinion on this. This is kind of off topic, but it is. So the communities that were vaccinated at a low rate had this spike of Delta, almost overwhelmed, sending us patients from Missouri, from St. Louis, because they had no critical care beds. I mean, absolutely five alarm, DEFCON 5 crisis, right? But it lasted for a brief period of time, and now it's kind of come back to these communities like what's COVID? They're back to normal. Where here in Cedar Rapids, in Link County, we have like a 65% and climbing vaccination rate. Our own employees, that's 4,000 or so. I think we're in almost the 90s%,
Mhm.
And so I think with the communities that have a high vaccination rate, the Delta moves through slower.
Mhm.
So you end up, rather than being overwhelmed with 120 really sick people in the hospital at one time, when you're just about ready at your breaking point and then it drops, that it's actually harder to do this sort of uh, prolonged plateau of 25 plus or minus 2 for weeks on end, because it's hard to continue to adrenalize the situation over a sustained period of time. Now, this is just my observation. I'm not saying that the vaccine, I'm still recommending the vaccine. That's good because less people die. But I think you're right. I think when we look back at this, we're gonna learn some things about ourselves, and as well as learn some things about just stress and dealing.
Yeah, I think, things could have been worse that first wave. And there were some people that were screaming like, hey, let's just get this over. We'll all get it. You will all get immune to it. And the initial attempts were about like flattening that curve, right? Flatten the curve so that we don't run out of ventilators, so we don't run out of hospital beds. And and for the most part, we were successful with that through a lot of the country. Um, you're right that, we might have a more of a slow burn ongoing, but I guess the the benefit of that hopefully would be that fewer people should die. We should be able to maintain our supplies. I mean, think about back last year, we literally didn't have surgical masks
Right.
for a
Yeah.
while. And we're very much in a different place, I think, because of our efforts to conserve those things and supply chain efforts. So there's benefits there. We've gotten more comfortable with caring for some of these patients. When we show up to work each day, I'm a hospitalist at St. Luke's, and I think it's a little bit more everyday practice now that we have a few patients with COVID. We kind of know what the standard care is. So you lose a little bit of that fear, a little bit of that excitement, and I think that's mostly a good thing in medicine. And we don't want to be dealing with an unknown and be unprepared. But you're right; it does seem like we're going to have a bit of this slow burn for a while still.
Yeah. Um, and you're absolutely right. I'm not saying it's good or bad. I'm just saying that I think that's why that's why it's so hard at times to have that slow plateau or persistent plateau is what I'm calling it. Because you end up with pandemic fatigue. And I've done a couple interviews, National Public Radio, some local television, saying that you don't call it burnout, okay? Because burnout is that the things that you've always done no longer provide emotional value to you and you're burned out, right?
Mm-hmm.
This
Sure.
is something totally different. I mean, this
Yeah.
isn't burnout. This is pandemic fatigue.
Yeah.
Uh, I've even heard people call it empathy fatigue. I don't know if I like that term because it kind of has a slight negative connotation, like you no longer have the ability to be empathetic, which there is probably such thing as empathy fatigue, but I don't really like to use that term. But um, as you said right before the podcast, it's gonna be interesting to look back and say and learn from everything because it's so hard to study something when you're part of the study
Yeah.
because you have observational bias, and I can't. Well, for a lot of reasons, I can't wait till we get through this. But it's gonna be interesting to look back on this.
For sure. Yep.
Yeah. Uh, Effectiveness of mask. You mentioned it. Mask. At the end of the day, they don't hurt,
Mm-hmm.
and
Yeah,
they
I
make.
think that's the biggest. I think that's the biggest thing, especially when we're talking about public policy. Like, yeah, there's not research behind like a community, recommendation for everyone to wear a mask in a restaurant or not. But if at the end of the day they don't hurt, I think that's what a lot of thought comes from. That like, if I don't know for sure if I'm going to spread it, and there's a chance that wearing a mask might help reduce it, it's something that I should be able to do, I think, as a member of a community, as a citizen, to help protect others. I do think we get spent a little bit too much time on the thought that the masks are helping us. I mean, there likely is some benefit there, but really, I think of wearing a mask as about not spreading my potential viral load to others. And uh, there might be settings, even with cloth masks or things like that, where they could be less efficacious. But I think if there's a chance at help and they're not causing me harm, it's a minor annoyance at times. It's a reasonable thing to do until we're really past the worst of this.
Well, I've been very vocal that I get frustrated because masks they should be put on correctly, not touched and worn once.
Mhm.
Anything beyond that, I think it loses the value, the benefit, but it doesn't never become a negative. I don't think it really,
Yeah.
I mean, I still think but the interesting, people say, well, there's no evidence that masks work. And it's kind of the analogy of there's no evidence that a study, placebo controlled, blinded, that jumping out of an airplane with or without a parachute, which group does better, right?
Right. Right.
Because why would you study that? Because it's obvious.
To
Being
me,
with
this would be much more controversial if it was a expensive, dangerous, invasive therapy, something like that, where it could potentially do harm. And I really don't see any reason to think that wearing a mask could cause harm to the mask wearer.
Although wearing a mask by yourself driving a car is still a little weird to me.
I will give you that. I've had
Yeah.
some strange looks at
Yeah.
people.
Um, the but back to the mask and just in general, I've been disappointed in the United States that we haven't done a better job of answering some of these fundamental questions. Some of them you and I are talking about right now: antibody testing, effective public health measures. I mean, we're the United States. We should be conducting these studies when we're getting the studies out of Thailand and Hong Kong. Not that the study is inferior. It's just I'm a little disappointed that our public health apparatus hasn't made a better effort to study some of these things transparently.
Yeah, I mean it's just been such a moving target. And you've said this before, like science is about the pursuit of knowledge, right? And I think recommendations keep changing as we get more information. And the
I
other
think you're
thing to
right.
come back to with the mask guidance initially, all the way back there, was we were concerned that we weren't going to have masks in the hospital. I mean, that was a big part of that recommendation of saying that no, you don't need to wear one out in the community because we need them in the hospital. Well, once that barrier went away, then they, I think, could get a little bit more generous with those guidelines. But now people might look back on that and say, like, see, you changed your tune here. First you told us not to wear it, now you're telling us to wear one. I think that's one reason why people started to lose a little trust.
Ivermectin. This has come out, and I've told you that I don't treat river blindness, so ivermectin is not a drug that I would think of.
Mhm.
And in preparation for this podcast, you and I had a conversation last week talking about what we're going to talk about and some of the questions that we need to answer. I mentioned to you like colchicine, which is an old drug, has been tried just about on every disease. I've even seen that colchicine might help COVID. Which is a gout medication, it inhibits the movement of white blood cells, so it reduces inflammation, which is it's a novel mechanism.
Mhm.
So I think that's why. But there's also the statins. I just saw an article come by today. Statins have an influence on it was a non-cardiac illness. I mean, so it's never ending where they're trying to find new indications for an older drug.
Right.
And do you know where did this ivermectin come from? Why would even it think? I mean, am I a bad doctor if you walked in my office with a viral illness and I said I'm going to give you something for river blindness? That
Yeah.
did I just
One,
miss
I
it?
think, yeah, I think it would be a bad doctor, but where did this come from? I think you and I know that like these studies are going on all the time for lots of things, right? And I don't think there's ever been this level of public scrutiny on primary literature, before. So like as soon as a new study comes out with a new medicine they're trying, hey, I mean, this was a new disease. They were gonna throw the kitchen sink at it and try to find something new. And that's the right thing to do, right? Like as scientists and physicians, like to try and fight a new disease, we need to try and find a new cure. So that's the right thing to do. Um, we all were initially on board with some evidence that hydroxychloroquine or Plaquenil was effective. Back in that initial spring, we started to use it for a short while. There were recommendations to do so. Um, that quickly became apparent that we were causing more harm than good, as patients were developing issues with cardiac arrhythmias, et cetera. And so we changed practice as more evidence became apparent and recommendations came out. I'll tell you this, like I'm a practicing physician in the mindset that the vast majority of what I do with patients should be pretty well recommended by our national bodies, for internal medicine or family practice or hospital medicine. And right now, it's very clear that they're not recommending the use of ivermectin based off the congregate analysis of all these studies. I think that for myself as a practicing physician, I do not see it as part of my regular duty to be going through primary literature all the time and trying what's new, or finding the new hottest thing. I think it is appropriate the way our healthcare system's set up to let the process work and let peer review studies be peer reviewed, go to journals, and then have consensus recommendations by those bodies. And we haven't got there with specifically with ivermectin. We're being recommended that it is not appropriate, that it's causing more harm than good. And perhaps it's more of a controversial thing because it is available over the counter, and that patients are able to get it in other places. They're not able to get some of these other prescription meds that have been experimental therapies. One that we seem to have stuck to in the hospital for hospitalized patients is knowing that a steroid, dexamethasone, has shown some benefit. But again, we're talking about pretty limited benefit, about like reducing the time and severity of symptoms. It's not a cure. And so the biggest thing I'd take away with the controversy of ivermectin is that we've still lost some of that patient, physician, provider trust. Like everything we do is based around that. And you have to understand as a patient that like your provider wants you to get better. If there's something there that we could use to make you get better, we'd do anything to get that to you safely. But you mentioned it before. At first, do no harm. We have to wait till we have evidence, and we know that we're not going to give you something that's going to cause harm. And no one's withholding any medicines from patients, because of government conspiracies or anything like that. We are following the scientific recommendations and guidelines and want to get you the best treatment as soon as possible. That's my biggest takeaway from it.
Yeah, I think I'm a little disappointed. I think if the boards of medicine and the media would have just said, yeah, if you and your doctor want to try ivermectin, that's you and your doctor's decision, and there's no evidence. It's tremendous amount of noise, but I keep right under the glass here on my desk that evidence, studies refuted over time, randomized controlled trials, 32% of them are refuted over time. Non-randomized controlled trials, 83%.
Mm-hmm.
And I keep that on my desk just to remind me that, what I'm doing today may really not be of benefit, but it sure as hell better not be of harm.
Yeah.
And
Absolutely.
I think that's the way you go into these conversations with the patient, that what is a benefit, but let's make sure it doesn't harm you.
Right.
Plaquenil is a safe drug when it's used appropriately. And if you're not using all the time, then you need to be careful of that. But then also you run into an issue, and we did this with Plaquenil back then. We looked at downstairs in the pharmacy, looked at our chronic Plaquenil prescriptions, and we set 3 months aside of Plaquenil
Mm-hmm.
for those patients, right? Because we were afraid that we could have a run on the pharmacy.
Mm-hmm.
And then these people that need it for their lupus, that need it for their rheumatoid arthritis, it wouldn't be there.
Right.
So that
Right.
was a decision that we made, that the patients sometimes if something might be of a benefit, but if you're taking away from another patient that it's proven to be a
Right.
benefit, proven to modify their disease, then that causes harm too.
Right. I get concerned specifically with the ivermectin talk that the more we talk about it, do we, increase this this controversy that amongst medical professionals, I don't really think is there. I don't think it's controversial right now amongst physicians and providers that the evidence is not there, that it doesn't help and it could cause harm. So to me,
Yeah,
that's not controversial.
I know you have a lot of interaction with the outpatient doctors more so than me, just in your position. But I would confidently say our medical staff is not walking around looking for
Right.
ivermectin, just
Right.
because it's the data's a lot of noise,
Right.
and it's just the Miami trial, beta blockers and heart attacks. That took 18 years before the Miami trial was completed, and it became standard practice because it kept being retested. That truth kept being relooked at because we didn't want to harm people,
Right.
and it's really hard just to throw something out there that can potentially harm.
So I'd encourage people to let's move on. We're going to keep looking at the data and studying drugs, and therapies as we can, but I don't think this is a controversial topic on that standpoint. And, don't get medicines from animal pharmaceutical companies. I think that's a pretty clear-cut recommendation.
Unless you're an animal.
Unless you're an animal. Think about those animals. They need
Yes.
the medicine too.
Yeah, that's that more to come on that. As far as I think that hopefully that will be cleared up someday and definitively answered, but it may not be. It may be one of those things. While we're talking about treatments that kind of came out of nowhere, vitamin D comes up a lot.
Mhm.
And I'm going to tell you a story that I think is really important. So, vitamin D is just now with the pandemic.
Right.
It's coming up all the time. And so there's a guy named Doc Carney. He was African American doctor, and he practiced in Brooklyn, Iowa. And he's my patient when I was in Grinnell. We became very good friends and watched a lot of Iowa basketball together with him. And I would see some of his patients, and they say, "Oh, I just need to get a Carney cocktail, and I'll feel better." I said, "What the hell, Carney cocktail?" So one time we're watching an Iowa game. I go, "Hey Doc, my patients, they always say they need a Carney cocktail. What is that?" And what he would do is he said, "Look, this is a true story." He said, "Look, patients get relative vitamin D depleted, and that's their cabin fever. It's not cabin fever. It's a sunshine vitamin deficiency that will go away once the sun comes out."
Mhm.
But what he would do is he would give them B12 and a steroid injection, in middle of February. They would feel great, he says, and then about the time that steroid wears off, they got their vitamin D levels up, and the sunshine came out, and the Carney cocktail worked. And I was like, that's crazy. But then over the years, 25 years later, I'm like, yeah, that does kind of make sense. So he was kind of ahead of his time, saying there's this cyclic phenomenon with vitamin D that if you test patients at the right time, they are going to be low.
Yeah.
And they might not feel. Sometimes I think some of this kind of achy and stiff feelings that people have, like in February, and they attribute it to, it's spring fever, cabin fever. I need to get outside. I think it's a relative vitamin D deficiency, and then they get
Sure.
it replaced, and they feel better. And so I'm not so sure that this vitamin D is more of a innocent bystander in a way, or coincidental.
Yeah.
What's your thoughts?
I'll date myself a little bit. I've only been out of out of residency for 7 or 8 years. But when I was in residency, vitamin D, I think, became really, really um, in vogue to check it for inpatients, a
Yeah.
lot in patients, and specifically in the nephrology community. It seemed like every time I worked with a nephrologist, we'd admit someone for sepsis or pneumonia, anything, and they'd say like, "Well, what's their vitamin D level?" And so it became very clear that sick patients had really low rates. A lot of them had low levels of vitamin D. I don't think what we know, though, is that if you artificially boost that up, does it change their outcome? And I think there has been some evidence in septic patients in the ICU, and that's where the idea for treating COVID, with vitamin D came from, because a lot of them meet criteria for sepsis. But again, yeah, like if you check all these patients, a lot of them are going to have low vitamin D levels, but we wonder like what's a normal vitamin D level? It's not really well established depending on where you live, your race, your skin color, things like that. And then are we going to change outcomes by artificially boosting that level up? And to me, that's unclear. It's generally a benign treatment, but it is a fat soluble vitamin. In theory, we could overdose someone with vitamin D and cause a problem. I don't think that happens very often, but that's probably one reason why it's kind of added on for some people's therapy, especially if they're severely ill in the hospital. Because again, we don't have a cure for COVID-19 right now. And so it's thought that if something might help a little bit and not harmful, that's why. But I think that comes back from a lot of the work around sepsis. It's not overly impressive that it's helpful. And, it's going to take more time to know if it really has an effect.
Yeah, and I think, you take a patient that's been in a nursing home for a
Yeah,
couple of years, how
right.
often are they out in the sun?
Exactly.
And you check it and they have a low vitamin D level.
Exactly.
I mean, when I take care of these patients, I do give them kind of what I call metabolic resuscitation, folate, thiamine, because these things can be depleted, they're water soluble, they'll be peed out. But you're absolutely right. Uh, the you can get in trouble with the fat soluble vitamins, A, D, E, and K. And I think one of the issues that I always worry about is patients overtaking vitamin D, which probably won't get them in a lot of trouble, particularly but if that's along with vitamin A,
Yeah.
that can be really toxic. That can cause liver failure. You can die
Yeah.
from vitamin
Yeah.
A.
And again, most of the time, supplementing someone that has a low level with, a normal supplement dose is not going to overdose them, especially in a controlled setting. But is it going to change their outcome? I think that we don't really know.
I mean, speaking of over time, when I was a senior resident in the early 90s, my grand rounds was on mineral corticoids and sepsis.
Mhm.
Okay. And at that time, it was recommended, thought
Yeah.
of benefit. And that has fricking gone back and
Yeah.
forth over the years that, I think as doctors, you eventually become in vogue if you just keep doing the same thing you did 20 years ago, because
Yep.
the pendulum comes
It'll,
back like, wow, he's really cutting edge. Nah, he's actually been doing that for 20 years. So, I mean, that's not even a controversy that's settled
right.
uh, over time. And that just reassures us that, science is the search for the truth, not finding the truth. Um, I'd like to wrap up talking about the vaccines and really get into. I really want to talk about some of the unusual things that people mention. Infertility, it alters my DNA. Um, I think the rare thrombotic events with the J&J vaccine, I think the myocarditis, pericarditis in young people is real.
Mhm.
It's not a contraindication for that, there is an association, and it's small, but
Mhm.
I think it's real, particularly young male adolescents with the myocarditis, pericarditis. So what's your been thoughts on that? Some of these things that are said.
Well, I'd want to start with, the the vaccine adverse information reporting system, the VAERS system, and I think that's where a lot of this came from. And we've tried to clarify it, even had specific questions, but again, that system is there to capture everything. So, if you get anything, the next day, if you stub your toe the day after getting a vaccine, VAERS would want to know about it, that you had some physical ailment right after getting the vaccine. They want to capture everything to make sure we're being as sensitive as possible and casting a wide net. So that is why, deaths, infections, all these sorts of things do get cataloged in the VAERS system after getting the COVID vaccine. But to this date, there's been none of those things have been shown to have any real cause and effect or statistical significance. And so, again, we're catching a lot of people die every day in this country, from all these reasons. All those will be cataloged in the VAERS system if they had got the COVID vaccine, shortly before.
If they volunteered for it. VAERS is VAERS stands for Vaccine Adverse Event Reporting System. But it's
Right. So
voluntary.
if it was reported.
And right. And I'm going to be completely honest with listeners and with you. I didn't even know VAERS existed until the pandemic.
Yeah. It was something.
Because I just ordered the vaccine that people needed. I support vaccines. Vaccines are in a lot of ways if you think about it, vaccines have saved more people than vaccines and a bar of soap are probably the two things that have saved more people in the history
Sure.
of mankind than
Yeah.
anything else that we do. And by bar of soap, I mean good hygiene,
Right.
not drinking contaminated water, etc. But I didn't even know VAERS existed. And
right. And so now we have this heightened, just societal awareness of that system, and a lot of people reading it and reading the logs. And so, to find all these adverse reported events, but in reality, none of them have been really linked as a cause or a cause and effect from the COVID vaccine. So I think that's the biggest part of it. Anytime you do something to millions of people, if there's a 0.0001 chance that you could get a rash or you could have a thrombotic event, something like that, that's an incredibly small chance. But if you do it to millions of people, you'll see a handful of those cases. Yeah, and I think that is okay to admit that there are those risks, very, very small risks, but we know that the risks of not getting vaccinated, I think, are much higher. So, that just comes back to the pros and cons, the safety profile of the vaccine. And it also speaks to how safe does this vaccine have to be authorized? Very safe, because you're going to do it to millions of people. And so we have to feel extremely confident that it's not going to cause a significant side effect, because a 1% chance, if you got a thrombotic event in 1% of people that had the vaccine, that'd be an incredibly high number of side effects, and it probably wouldn't be safe enough to give to the public. So, I'm incredibly confident.
I think we're approaching 7 billion doses.
Yeah. Yeah.
And so even if you have, a million adverse reactions, that's still a small percentage.
Right.
Yeah.
Incredibly small. So I think that's important to know, for the public. It comes back to that trust too, that their physician and providers, they want what's best for them, and that we feel really confident in the safety of these vaccines. And so that's I think the biggest thing to take away from it. The really far out there controversies or conspiracy theories, I don't know how to speak to that level of mistrust. That's something, a larger societal issue. If people would believe that there's microchips going on or things like that, I think that's kind of outside the realm of what we think of as medicine or typical medical care. There's something funky going on there if that's what people are believing. But I think there's an extreme amount of evidence out there walking around with all of us that have been vaccinated, the millions and millions or billions of doses given, and knowing that the vast majority of us are doing just fine.
And another thing that I think on the vaccines, particularly messenger RNA, is that it doesn't get into our DNA
Right.
I think that's a lack of understanding of the cellular mechanics of messenger RNA, transfer RNA, et cetera. But, that technology, I remember reading about that in college, 1990.
Mhm.
You know,
It's really
it,
exciting. I mean,
yeah,
it's
it is,
amazing.
and it's been around for a while. So to say that messenger RNA technology is not safe, I don't know. You can say that. You could say maybe it's not effective in this case,
Yeah.
but and maybe, and I've said this to you, and I've said it to on other podcasts. The vaccines may end up being a therapeutic and not necessarily a vaccine.
Mhm.
And we could someday have messenger RNA technology that a type 1 diabetic could have the beta isolate cells make insulin, and they have to
Yeah.
get a shot twice a year with
Yep.
messenger RNA to tell those cells to make insulin
Yep.
and cure diabetes. I mean, so
And we
there
might
the
we might just
horizon
say,
of messenger RNA technology is just amazing.
yeah, and this pandemic, this sped up process to now get billions of those doses out in people, like might be, a just a landmark study in the safety and efficacy of mRNA. The fact that we've done it so much and the safety profile has been really, really remarkable. That's potentially really exciting for the future.
I think one issue that I think I don't know if you can change it, but people work at the FDA and the CDC, and then they go get a lucrative job with big pharma, and then it calls into question what was their stewardship and consumer protection
Sure.
mentality.
Yep.
You have big pharma, they come with a vaccine. The government says, okay, well, since it's hard to prove true, and related to some of these side effects, right, or not related, we're going to make you immune from lawsuits related to the vaccine because we have to have vaccines. Like I said, bar soap and vaccines have saved more lives than anything.
Yep.
Well, then people look at that retrospectively and they say, okay, well, it's clear that they're in bed with big pharma, and that's why they won't let me have vitamin D or azithromycin or hydroxychloroquine because they want, the
Yep. Yeah, and that's just a result of we do have a huge problem with big pharma in this country. The fact that we advertise for prescription medications and things like that, I mean, on one hand is kind of ridiculous. And so it is kind of speaking out of both sides of our mouths. And I think there is a big issue with the way pharmaceuticals are set up in this country. The money there, the cost to our patients is unbelievable and not sustainable. But we also, in this light, from a vaccine, are very much dependent on them getting this vaccine up, and it's been a lifesaver for many.
I think also you can go back, you can use that also to address some of these controversies that unfortunately in medicine, big pharma profits motivate the company because they're a company, right? They're not
Yep.
and but you also can look at some of these other things about causing people to be infertile and microchips. Where's the money in that? They don't
Right.
do anything for money. So you can't have it both ways. You can't criticize them for making a profit and then accuse them of doing something that would prevent them from making a profit.
Yeah, that's
It,
that's a really good point. And the infertility thing is, it's understandable that people at this stage in their life are just really, really cautious, and anyone who struggle with that is extremely distressed about making sure they're taking care of their body the right way. And I think you talked about before, it's about empathy. A lot of those people are just trying to do what's best for them. Um, it's been really well established right now. It doesn't cause infertility. And the other thing that is becoming more and more apparent is how many more patients that are pregnant are having bad outcomes with COVID. And it just speaks back to it's even more important that those patients get vaccinated because we have otherwise healthy, young women, potential mothers and such, and babies that many have died from. So it's
well,
just,
and you probably know this. I approve all monoclonal antibody orders just because of the shortage. So there's good stewardship there. So every single case I review, right?
yeah,
And I can tell you, and again, the sample size here, small, less than 40, but all the pregnant women that we've given monoclonal antibodies to, they did not become hospitalized with
yeah,
COVID.
yeah.
So, and I'm glad to see our local obstetricians. I love to see their names on these orders because I do think it is preventing hospitalization. It's just human nature that, you treat pregnant patients different because you have two patients
Right.
and we all had moms and we look at them differently and we do give them a little bit. So I don't see it as controversial on that some agencies and some employers have said, we're going to defer the vaccine during pregnancy.
Mhm.
I don't think that's not sending a signal that they don't believe in vaccines. I don't think that's true at all. I think what it's saying is, Dustin, like you said, 83% of non-randomized controlled trials go away over time. It's a pregnant mom. I just don't want to. I don't want to put them through this. Let's wait 90 days. I think that's completely fine.
Right. Give them pause. Give them some grace to think it through. I think it's a very reasonable thing, but it's just become very apparent how at risk that population is too. And I'm really excited to hear, especially locally, of our obstetricians, how supportive they've been. And I think that the last month or two, it seems like they've even accelerated in that process and ensured their patients are aware. So
yep.
Really
I
kudos
just
to them.
approved two of them prior to this podcast. Orders came in.
That's great.
So that really is good. Well, Evan, thanks for coming and joining me. And I think we'll have you back, and maybe we'll talk about, we'll see if there's some more data comes out about the Merck pill,
that's
which I
exciting.
think is really exciting. I mentioned
Yep.
that yesterday in the podcast, so I think I'd like to have you come back, and maybe we can talk about that, as well as the Cleveland Clinic study on natural immunity, at least coming out saying, maybe you should booster and give a third dose to other people, not people that've had it, because, we're once again, good or bad, the United States has an overwhelmingly very efficient healthcare system. Our rates of vaccinations exceed other countries by a lot, particularly developing countries. And I think it's reasonable to look at these studies from a standpoint of stewardship. That should this group of people get the vaccine,
Sure.
or a second dose or third dose, or should we get to these people that they have no healthcare infrastructure? I think that's a good conversation to have. So once again, this is Dr. Evan Diehl, Vice President, Medical Director for UnityPoint Clinic, Cedar Rapids. That's kind of like being principal of a homeschool, isn't it?
Yeah, something like that. No comment.
No comment. All right. Thank you for listening to COVID-19 Update. For the latest on COVID-19 vaccine information and more, visit unitypoint.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.